Bismillahirrahmanirrahim. Good morning, everyone, all my colleagues. This is Dr. Nida Anwar from NIBD Hospital, Karachi, Pakistan. I thank wholeheartedly PSH Forum, Dr. Salman Adil, Dr. Natasha, Dr. Uzma Zaidi for giving me this opportunity to moderate this session today on acute leukemia and myeloproliferative neoplasms. Today, I would like to welcome my chair, Dr. Ayaz Mir, who is consultant hematologist and director, bone marrow and stem cell transplant at Shifa International Hospital, Karachi, Islamabad. I would also welcome my co-chairs, Professor Dr. Syed Mohammad Irfan, who is a consultant hematologist and head of Department of Hematology at Liaquat National Hospital, Karachi, Pakistan, and Dr. Usman Shaikh, who is Associate Professor Hematology at Aga Khan University Hospital, Karachi. I would also want to welcome my panelist, Dr. Uzma Zaidi, who is a consultant hematologist at NIBD Hospital, Karachi, Dr. Raheel Iftikhar, who is a consultant hematologist at National Institute of Blood and Bone Marrow Transplant, Dr. Shahzad Nasir Raja, who is a consultant hematologist at Quaid-e-Azam International Hospital, Dr. Syed Muhammad Irfan, and Dr. Aisha Jamal, who is a consultant clinical hematologist at NIBD Hospital, Karachi. I am very grateful to all my respected speakers who have given us the opportunity to listen to them and to contribute their expertise, their talks, right from USA and UK. In spite of all the reservations of the time, they've joined us. So I would start my first talk, that is on therapeutic options for treating myelofibrosis. I welcome Professor Dr. Srdan Verstovsek, who is a medical hematologist and oncologist and professor of medicine at the Department of Leukemia at MD Anderson Cancer Center, Texas. Dr. Srdan is a clinical and translational research expert in developing new therapies for myeloproliferative neoplasms. I welcome Dr. Srdan.
Hello and welcome. I am Srdan Verstovsek. I'm professor of medicine in the leukemia department at MD Anderson Cancer Center in Houston, Texas. Today, over the next 20 minutes, I'm going to talk on the therapeutic options for treating primary myelofibrosis patients. And specifically today, I would like to focus on the life extension, and that is an unusual topic, I should say, life extension of myelofibrosis patients. As an example, here is one of my patients at presentation to my clinic on the left side, and 7 years later, living and enjoying life with the controlled disease, no elimination of disease, but controlling the disease very well for a very long period of time, which I think is a realistic goal for us all to achieve in therapy of our patients with myelofibrosis. So let's talk about ruxolitinib. Ruxolitinib has been around for many years now around the globe, and it is standard practice medication for patients with myelofibrosis that have advanced features with symptoms. Number one is symptoms. That can be general systemic symptoms, night sweating, low-grade fevers, itching, and others, or symptomatic splenomegaly. Certainly, it's not therapy for anemia because it can cause anemia. We're going to talk about that actually. But already in 2014, as you can see on this slide, there was an indication of possibly extending life by controlling signs and symptoms of the disease with ruxolitinib when the outcome of the patients that were on COMFORT-2 study, one of the two phase 3 studies that led to its approval, the outcome of patients on COMFORT-2 study that were treated with ruxolitinib was compared to a very well organized database that led to development of DIPSS prognosis scoring system. So very detailed database that served a purpose for comparing the outcome. And there was a suggestion of significant prolongation life already there. Now, since then, there are many other reports of such a possibility. Here is one of the more recent ones that actually was just published as a paper just a couple months ago, presented last year at the American Society of Haematology meeting from a real-world analysis of patients' outcome from Medicare fee-for-service claim database, which is United States-based federal database. In that database, if you just focus here, perhaps on the right side, to survival graphs, what we see is in the orange survival curve, the survival of myelofibrosis pre-approval to ruxolitinib. And in the United States, you may know the ruxolitinib was approved in late 2011. And then in the middle curve, that is the post-approval ruxolitinib unexposed patients, which just gives me a good feeling that we are making progress in treating patients and making them live longer one way or the other over the last 10 years. These are those post-approval ruxolitinib unexposed patients. But the best outcome in this analysis is the top line, the survival curve here that says post-approval with the ruxolitinib exposure. What ruxolitinib does is gives you extra kick in the survival benefit. And it's very significant, as you can see. Now, many ask the question, how about comparing this to the standard practice, old standard practice hydroxyurea, which is still being used? And here is the answer. This is from last summer, from a European Hematology Association presentation of an ongoing analysis of prospectively acquired patients in EARNEST database. EARNEST is the prospective compilation of the patients treated for myelofibrosis in Europe. So here you have a matching analysis of patients that were treated with ruxolitinib versus hydroxyurea. Matching meaning the patient's same characteristics. And you can obviously see survival benefit by exposure to ruxolitinib versus standard old-fashioned hydroxyurea. Now, we at our own center, we do see quite a good number of patients. We ask a question of influence of ruxolitinib on outcome as well. But first is to start with our first question in this analysis, published as a paper just a few months ago in the Clinical Lymphoma, Myeloma, and Leukemia. Our first question was, what's the influence of the blast, percent of blast in bone marrow on the outcome of the patients? That's in the middle of the slides here. And you can see here in the blue color, the best outcome patients with 0 to 1% blast, then in orange 2 to 4% blast, 5 to 9% blast, and then more than 10% blast. So just the blast percentage has an influence on the overall survival of the patients. But of course, we then ask the questions, what about the therapy with ruxolitinib? And if you go from the middle to the right, you see always the two curves. The better curve is those patients exposed to ruxolitinib. So right middle panel, then the left lower panel in the red color are always survival curves for patients treated with ruxolitinib. No matter what the percentage of the blast is from 0 up to 10, you always have that survival benefit of ruxolitinib. When you don't have it in a patients that have a 10 or more blast, these are so-called accelerated phase patients. So another convincing evidence of a benefit on survival with therapy with ruxolitinib. Of course, we all probably know that the COMFORT 1 and 2 studies suggested that survival benefit as well. That led actually to adjustment of the FDA assignment of ruxolitinib as a therapy for myelofibrosis in the United States on a label for its use. That it says that it can prolong survival. That is on a label for its use in the United States. And that's based on this comparison in top line here, survival patients treated with ruxolitinib from the day one versus those in control groups in the middle, where majority were given to ruxolitinib, versus in blue line, patients that were not exposed to ruxolitinib. So about a 3 years gain. Now, what I want to emphasize is that earlier intervention appears to matter. These are from the same analysis, same paper from 2017, analysis based on intermediate 2 versus high-risk patients, because only these two groups were allowed to participate. As you can see in the top two lines, this is the ruxolitinib extension of life in intermediate 2-risk patients versus control. In the bottom two lines is the high-risk patients, and you can appreciate very vividly here that there is much more life gained with the intermediate 2-risk group versus high risk. Now, this might be very important. As it has been shown many times in the past, One factor that is relatively well established as important for influence on the survival of the patients is the degree of a spleen reduction. That has been repeated so many times, I hope everybody knows. From the clinical studies on the left side, here is the correlation, as you can see, between the ruxolitinib-treated patients and their response in the spleen. Better the spleen reduction, the longer the life of the patients. And in a lower part on the left side, the worse the spleen gets in the control arm, the shorter the survival. That was also seen in the everyday practice on the right side from Italy. Dr. Palandri published this paper some years ago saying that those patients that by palpation, because we don't use CAT scans or MRIs in everyday practice, those that achieve 50% reduction by palpation have a better survival. Again, this is on the right side here. And then we know that the dose matter. The dose is correlated directly with the degree of a spleen reduction in the left upper panel. That is from the COMFORT studies. COMFORT 1 study, you see that the doses correlate very well. The doses 5 milligrams twice a day or less are not very effective whatsoever. They can be temporarily used, I should say. There are occasional patients where it works, but 10 milligrams twice a day or higher is preferred. While for the symptoms, which is in left lower panel, 10 milligrams twice a day is good enough. But of course, we want people to feel well and have a smaller spleen and live longer. The same type of correlation was published from analysis of outcome of the patients in everyday practice. This is on the right side. Ruxolitinib starting dose matters, and then ruxolitinib average dose over first 3 months matters as well. So I should say that there is a convincing evidence that there is a significant correlation between the dosing and the spleen response. And by default, then, the spleen is the goal of the therapy because it's related to a survival benefit. Now, if you look through studies that were done so far and account for another factor, a risk of dying to account for the survival benefit, then you can see that intermediate to and high risk patients that were part of the COMFORT 1 studies, as compared to intermediate 1 risk patients from 3 other sources, the more advanced patients have a not as good response as the more advanced patients. Look just at the lower part of this table. These are intermediate 1 risk patients. They have better spleen response. They have less of anemia, less of thrombocytopenia, less of infections, and less of discontinuations. So intermediate 1 risk patients may possibly achieve higher response rates and experience lower toxicities than patients with high risk disease. I should say that's logical because they have a less of anemia and thrombocytopenia at the baseline, the 2 factors that affect the dosing of ruxolitinib. Now, why would people live longer? I have shown this in the past, and I think to me, this is quite convincing. The albumin goes up, the body habitus change, the cholesterol improves, the metabolism in the body changes. People, again, look normal. With the improving body weight and metabolism, your performance status improves. And in addition, the kidney function improves, which would say organ function improves. And there is correlation here on the right side between the kidney improvement, renal improvement, and the failure-free survival. So better improvement in organs, metabolism, walking, performance status lead to that durability. People live longer with the controlled signs and symptoms of the disease. Now, a rationale for earlier use of ruxolitinib then lays in 2 camps. And this is from the paper from Dr. Palandri to 2017. I should say 2 types of important findings so far summarized in this slide and in these 408 patients analyzed to confirm that findings. I should actually start with the right side, the influence of dose. I think I made the case. Early myelofibrosis patients tolerate the higher dose. The higher dose, they have a better response. Lower dose may not have such a good response. I want to focus a little bit more on the right side. Spleen and symptom response are lower if the patients are more advanced by the prognosis scoring systems. I think that's also logical. They have a larger spleen, they have a more of the anemia and thrombocytopenia as it's listed in the table on the left side. But I want to also point this one that came to me vividly just recently. It says time interval between the myelofibrosis diagnosis and start of ruxolitinib also matters. That may not be appreciated so far. So we actually look at that. This is presentation from 2 months ago from American Society of Haematology meeting that we asked that question. Does the early intervention in myelofibrosis impact outcomes? I'm not talking about the intermediate 1 versus intermediate 2 or high-risk patients, which I think convincing data already exists for that to say yes, earlier intervention in less sick patients in terms of the risk of dying matters because they are not so sick, they can sustain better dose, the better spleen response, and they may live longer. This is the analysis within the COMFORT 1 and 2 studies where everybody was intermediate 2 and high risk. So the question was earlier intervention in terms of the timeline from the diagnosis to a therapy. So we divided 500, 250 patients into groups, as you can see in the middle of the table. Ruxolitinib-treated patients, myelofibrosis diagnosis within a year or after 12 months. The same for the placebo. And we compare their characteristics. And if you look at their characteristics, they're about the same. The hemoglobin was 113 versus 106, platelets 320, 303. You would not see extraordinary differences between these two groups as we divide them between time frame when they were treated relative to diagnosis, within a year of diagnosis or after. So, however, this is surprising perhaps, but it is very useful to understand that there were fewer thrombocytopenia and anemia events observed among those who initiated ruxolitinib treatment early, within a year of diagnosis. Although they start, if you look at thrombocytopenia on the left side, at about the same levels as I showed on the previous table or on the previous slide, they experience less of thrombocytopenia. The same for anemia, less of anemia in patients that are treated earlier in their life with the myelofibrosis. The response, therefore, I should say that all makes sense to me, is better in patients who are treated earlier on in disease course. If you look to the graphs on the left side, this is ruxolitinib-treated patients. Within a year, in the dark colors, in the orange color, it's after 1 year of having diagnosis. There is a difference. If you look at week 48, this is the next set of bars, 44% are still responding versus about 27. So earlier intervention appears to matter. There is less of cytopenias, and there is better spleen response. And finally, on the right side, you can see here that the durability of that response matters as well. It's different. The earlier intervention have a better spleen response, less of cytopenia, and durability of that response. You can see here durability between the two groups. Earlier intervention patients have a longer benefit. And finally, that translates to overall survival. If you just look at that graph here on the left, on the right side, the top two curves, these are treated patients with ruxolitinib. Within a year, the best survival, and orange is later on in the course of the disease. Interestingly, the same appears to some extent, at least, to be the case for patients that were given a best available therapy. However, the difference is much more pronounced with ruxolitinib. So overall survival was longer with ruxolitinib versus placebo or best available therapy, regardless of the disease duration. And within a group of ruxolitinib-treated patients, those that were exposed to ruxolitinib within a year of diagnosis have much better outcome. Now, there are other factors that matter. These are not standard practice tests. You can do extensive molecular testing, and some academic centers do that. We do that here, but it's not everyday routine practice. Some of the mutations that can be present in these patients at the beginning of therapy with ruxolitinib will affect the extent of the benefit and durability. In our experience, these three mutations that are listed here on the left side do affect the chance of good response and the durability of response. Others have looked at that, and this is one paper from 2017 that again looked at the characteristics of the patients and to project the durability of the response. And this particular investigator said, if you see here on the middle of the slide, it says transfusion dependency before starting therapy, high risk of dying by prognosis scoring systems, and genetic complexity. They all affect the time to treatment failure and overall survival. I agree. We talked particularly about patients' characteristics based on blood cell count and risk of dying as unfavorable. If you do genetic testing, then the genetic complexity is another factor. What does this really mean for the patient is that you should consider intervention earlier with the transplant, for example. And that is quite interesting topic. When actually should you intervene with the transplant? Based on the papers like this, where you look at the overall survival of different groups of patients that are treated with the JAK inhibitors, usual conclusion is that you should intervene earlier rather than later, because the overall survival after transplant is best in group A here, which is the group that went into the transplant when they had a clinical improvement while on JAK inhibitor. So we would usually say go to the transplant when you achieve the best response with the JAK inhibitor. Well, investigators in Canada said that perhaps that is not the best way. They compare survival of the patients, as you can see here on the right side, those that went to transplant upfront versus those that were first given JAK inhibitor and then benefited from them for some time and then went to the transplant. And just to go through that curve here, what you can see here is that the transplant, perhaps long-term, after some years, had a benefit, but there was some loss of life. I should perhaps be too harsh and say unnecessary loss of life with earlier intervention, which that put a point here for discussion. Should we first try to optimize the care with the JAK inhibitors and maintain it as long as possible before we rush into the transplant? Can we predict on therapy who will do poorly, and we should really go earlier with the transplant rather than delaying it while maintaining a good control of the disease with JAK inhibitor? One factor is leukocytosis. And if progressive leukocytosis happens in these patients, we should certainly consider transplant sooner. The main reason for failing ruxolitinib is anemia. That has been known. What can we do about anemia? Not too much. We can do erythropoietin stimulating agents. We can do danazol, thalidomide, lenalidomide. Many times we combine this with the JAK inhibitors together. But there is alternative dosing regimen now developed for ruxolitinib. In people who are anemic at the beginning of therapy with ruxolitinib, you should start with 10 milligrams twice a day and go up. So start low and go up. With that, you save perhaps some myelosuppression, and you have still good response. Look at this waterfall curve, 56% response rate by palpation with this alternative dosing regimen. And as you can see here, hemoglobin levels appear to be stable. So remember, alternative dosing regimen has been published 6 months ago, going from low dose, 10 milligrams twice a day, up to the 15 or 20, 25 milligrams twice a day to optimize the care with less myelosuppression, the same approach that you are, I hope, doing for patients with low platelets. This was also published recently as an update for patients with platelets below 100. Start with 10 and go up. So I should say, let's make it simple. Any patient who is at the beginning of therapy with ruxolitinib, either anemic or thrombocytopenic already, start with 10 and go from 10 to 15 to 20 to 25 to maximum safe dose, first to control the symptoms, second to decrease the spleen as much as possible, and then to prolong life. You can even re-challenge patients with ruxolitinib once you stop it. This was analysis of patients who stop ruxolitinib for at least 2 weeks and survived for a month, so not progressing. If you re-challenge patients with ruxolitinib, you can get that survival benefit as well. So I want to thank you very much for your attention and give you another view of some of my patients. This is 2008, and this is now. Imagine how many years this patient survived with a good control of signs and symptoms. So I thank you very much for your attention. I hope this was useful for your everyday practice. Thank you.
So our next talk is about risk-based management of polycythemia vera by Dr. Claire Harrison. Dr. Claire Harrison is professor at Guy's and Thomas Hospital, London, UK. Her focus of clinical research is on polycythemia vera and MPNs. She's also one of the chief investigators in several trials, including COMFORT-2 trial. So we proceed with the talk.
Hello, my name is Claire Harrison. I'm a consultant haematologist at Guy's and St Thomas's Hospitals in London. Thank you for the wonderful invitation to speak at your meeting on the subject of risk-based management of polycythemia vera. These are my disclosures. Now, as we know, polycythemia vera is a clonal chronic myeloproliferative neoplasm. Causes of death for patients are well known to be linked to both thrombosis and other malignancies, as you can see here on the left, reflected in the data from the Swedish Cancer Registry, showing cardiovascular and cerebrovascular endpoints and hematological and solid cancers. And this is also true in the most recent data from a group of American patients presented at ASH in 2020, shown here on the right. Polycythemia vera is also associated with a range of symptoms which have an impact upon quality of life for patients, which have been increasingly recognised in recent years. Here is some data from the ex-US landmark study showing impacts on work for PV patients, including up to 15% of patients reducing their time at work, and then 5 to 10% of patients voluntarily terminating their job, taking an early retirement, etc., which compares with other myeloproliferative neoplasms. These then are all factors which we must take into account when we are considering therapy for this condition. Traditionally, our aim has been to prevent thrombotic and hemorrhagic events, ideally reducing risk of transformation, although there is minimum evidence that current therapies do this, whilst minimising treatment-related morbidity, controlling symptoms, managing emotional and psychological burden, and also keeping an eye on special situations such as pregnancy and surgery, which we will not be discussing today. Treatment for patients then and physicians are guided by different aspects. This is more data from the landmark study where a group of patients and a group of physicians were asked what treatment choice for PV was based upon. For physicians, one can clearly see the aim is to prevent vascular events, improve symptoms, and give patients better quality of life. Interestingly, the focus for the patients were on both healthy blood counts and preventing vascular events, but also a key importance for patients is a focus on slowing or delaying condition progression. I'd like to base the rest of my talk around a clinical case managed in our hospital. This was a 52-year-old female patient who was referred with a chance finding of thrombocytosis, but was found to have an elevated hemoglobin and hematocrit at the time of presentation. She was otherwise well. A diagnosis of polycythemia vera was confirmed using the WHO diagnostic criteria. Usually in my centre, I would perform a bone marrow biopsy, although this is not strictly necessary according to these criteria in a patient with such marked elevation of the hemoglobin and hematocrit. Bearing in mind the dominant complication of vascular events, a careful review of vascular risk factors is needed for our patients, and for this patient at that time, there were no vascular risk factors. She was therefore a low-risk PV patient and was treated with aspirin, low-dose aspirin as evidenced from the ECLAP study, and venesection with a target hematocrit of less than 0.45 as evidenced from the CYTO-PV study. Beyond the basic tenets of management such as aspirin and venesection, we must decide if our patient is a low or a high risk patient. And the conventional risk stratification for patients with PV is shown on this slide. They are low risk if they have neither age over 60 or more recently we have adopted an age cutoff of 65 years and or a prior thrombotic event. It should be noted that extreme thrombocytosis is associated with increased risk of hemorrhage and is an indication for treatment, although not necessarily a risk factor for thrombosis. So when we compare our PV patients, and indeed data is shown for ET on this slide, here are the PV patients, low and high risk, and here's the annual event rate of thrombotic events. And here you can see that even a low-risk PV patient has an annual risk of a thrombotic event, which is double that of a normal population with cardiovascular risk factors, such as those listed here. So when you consider a PV patient, it's also important to think about cardiovascular risk in addition to our standard risk factors. So just illustrated here from a presentation from colleagues in Italy is that added risk, for example, of hypertension for patients with polycythemia vera. Other factors predicting thrombosis include leukocytosis. Here is the data from the CYTO-PV study, which was the prospective study looking at treatment intensity in terms of control of hematocrit. And here you can see that a white cell count just outside the normal range is associated with an almost fourfold hazard ratio for increase in risk of thrombosis. The JAK2 driver mutation is known to be of diagnostic importance, but the variant allele frequency is also linked, as you can see here, to thrombosis, hemorrhage, and risk of evolution to myelofibrosis. This is a static measurement of variant allele frequency, not so much change in that. What about the frequency of phlebotomy or venisections? Mathematically, we could hypothetically represent hematocrit fluctuation and supplemental phlebotomy and suggest that time above the line would be associated with time at risk, and so frequent venesection could be a risk for thrombosis. It's certainly inconvenient for our patients and a burden for healthcare. Whether it is a risk for thrombosis is actually covered with conflicting data from Spanish and Italian registries. Beyond risks for thrombosis, there are also risk factors for disease transformation, principally and most commonly to post-PV myelofibrosis. This is dominated by clinical risk factors such as age, leukocytosis, disease duration, baseline reticulin fibrosis and splenomegaly, but there is also the genetic risk factor, which I showed you earlier, of JAK2 variant allele frequency. For the development of leukemia, in addition to the clinical parameters, of course, abnormal karyotype and specific mutations in genes such as TP53 and RUNX1, as well as prior therapy, are important factors. So let's take a look at our patient. She continues to have aspirin and venesection, develops progressive severe fatigue and low mood. Probably these were linked. And at age 56, she's diagnosed with hypertension. In view of the hypertension and also her severe symptoms, since the hypertension was well controlled, we made a decision to designate this patient as a high-risk patient and recommend a cytoreductive therapy. So in 2021-2022, a patient in our centre with high-risk PV would be offered either hydroxycarbamide or hydroxyurea as a standard first-line therapy used very commonly across the world, or interferon alpha, specifically pegylated interferon alpha 2A. The relative benefits of these therapies has been studied for many years, and most recently from the group at Cornell in a retrospective study of 470 patients, comparing those either treated with interferon, here in red, hydroxyurea in green, or phlebotomy only. There appeared to be superior myelofibrosis-free and overall survival for interferon-treated patients. Management with phlebotomy alone was associated with a higher risk of MF transformation. But it's very important to be cautious in interpreting this data, since patients treated with recombinant interferon tend to be younger and have lower risks of these events. And it's also important to note that these events of transformation did still occur. More recently, we have seen final results from the PROUD and continuation PV study, which compared a new formulation of recombinant interferon alpha 2B, so-called ROPEG interferon or Besremi, and hydroxycarbamide upfront in patients with PV. In this study, which was a non-inferiority study with a primary endpoint of control of hematocrit, the two therapies were equivalent. They were not equivalent, however, for control of the JAK allele burden, which fell progressively for patients treated with interferon, and for patients with hydroxycarbamide, even after an initial drop, this did not really change. However, clinical benefit of these molecular responses, which do not reach the state of minimal residual disease, according to, for example, acute leukemia or chronic myeloid leukemia practice, their clinical benefit in patients with PV is uncertain. What about major thromboembolic events? So after 419 patient years in the ROPEG interferon arm and 338 years in the control arm, rates of major thromboembolic events were relatively low, approximately 1.5% per patient year in each arm, and not different between the two arms. Another important practice point from this slide, however, is to illustrate the fact that most of these events occurred in patients who did not have good control of their blood counts. Our patient chose to take hydroxycarbamide, which incidentally had a major benefit on her fatigue. She takes a large dose, 2 grams per day, and after 5 years is reviewed in the clinic with a white cell count of 21. She's free of phlebotomy and the platelet count is 450. So the option for us as a treating doctor is illustrated on this slide. We could choose specifically to designate this patient as hydroxyurea resistant, but we should first check, of course, compliance. Then the options are to either increase the dose of hydroxycarbamide, but this is quite a high dose actually. I wouldn't be tempted to use a higher dose in a female patient. We could switch to ruxolitinib, a targeted therapy, or switch her to interferon alpha as the alternative first-line therapy. This slide just shows the ELN consensus criteria for hydroxyurea resistance and intolerance in PV. This patient clearly met criteria for resistance with a white count of 21 and a platelet count of more than 400 on a maximum tolerated dose of hydroxyurea. Below are the criteria for intolerance and mucocutaneous, for example, toxicity is a dominant feature here. It is important to recognise resistance to hydroxycarbamide as it is associated with increased risk of death and transformation, and this is particularly seen in those patients who have cytopenia. What is the data for current therapies in the second-line setting? Well, here is some data for interferon alpha from the MD Anderson showing actually that many patients tolerated this agent for a long time, but ultimately 1 in 5 will discontinue treatment due to treatment-related toxicity. This is also true in the frontline setting. And unprovoked major vascular thromboembolic events, hemorrhage and disease progressions continue to occur. Ruxolitinib, a JAK1 and 2 inhibitor, is also licensed in the second-line setting on the basis of the response and response to study design, where this agent was compared to best available therapy in resistant and intolerant patients with or without splenomegaly. This agent controlled the blood count beyond the hematocrit, reduced symptoms and reduced splenomegaly. And in the 5-year update of the Response 1 study, which was published recently, the rates of thromboembolic events may give the impression of being lower with ruxolitinib. There is definitely an increased risk of non-melanoma skin cancer in these patients who are often heavily pretreated with hydroxycarbamide, and probably no difference in rates of transformation. The question of whether ruxolitinib does indeed reduce risk of thrombosis is still being asked, But there are, of course, several reasons why this might be the case. For example, it is a good agent for controlling the hematocrit, leukocytosis, as we've already seen, and its actions upon inflammation, the JAK allele burden, and the mutated endothelium, which has been reported in several patients. So for second-line therapy for our patients, we have the option of adding ruxolitinib, and in the third line, we really have very few therapies such as busulfan or the alkylating agent pipabroman or radioactive phosphorus. And there are experimental therapies that are being looked at in this setting, such as a histone deacetylase inhibitor, MDM2 antagonists, and more recently, PTG or rusfertide, targeting iron pathways. In summary, polycythemia vera continues to be managed using a risk-based approach, which we have discussed today, centered upon thrombosis risk. We've also discussed standard and broader risk factors for these events, as well as disease management. Questions for the future include whether we should treat earlier in the disease course, monitor the JAK allele burden, and perhaps further investigate targeting the iron pathway. Thank you very much for your attention.
So our next talk would be regarding the risk-based management of acute myeloid leukemia by Dr. Talha Badar. Dr. Badar is hematology oncology faculty at Mayo Clinic, Florida. His research interest is acute leukemia, and his current research focus on genomic landscapes of acute myeloid leukemia. So can we please proceed with his talk?
Good morning, everyone. First of all, I would like to thank the organizing committee of HemCon 2022, organized by Pakistan Society of Haematology, for giving me the opportunity to discuss management of AML. I'm really excited to present today. My name is Dr. Talha Badar. I'm a leukemia faculty at Mayo Clinic, Florida. So we'll be talking today about risk-adapted approach for management of acute myeloid leukemia in adults. So today we'll be discussing about the background of the disease, the diagnosis and prognostic classification of AML, approval of novel and target therapy over the last 5 to 7 years in this field. Then we'll spend some time about risk-adapted or individualized treatment of acute myeloid leukemia in adults, and then we'll conclude. I just want to let you know that I'll be talking mainly about non-M3 AML, excluding patients with APL, whom tends to have a better prognosis and better outcome. So AML disease burden, in the US, we see around 20,000 cases of AML per year, with around 11,000 deaths. AML is a disease of elderly and median age around 70 years. And although there is significant improvement over the last 5 to 7 years, but it continues to have a dismal outcome with 5 years survival reported in the most recent CS data around 29%. So this is the graph showing incidence and survival trends over the years. We have made some progress in managing this disease. And as you can see in this graph, the number of deaths has decreased over time, and the outcome has improved over time with this disease. So this is the slides I've taken from the MD Anderson data, in which you can appreciate the improvement in survival outcomes of patient AML. On the left-hand side, you can see the age, less than 6 years of age patients treated since 1970s to up to 2010. And on the right side, you can see the survival outcomes and survival trends of patients more than 6 years of age. And you can clearly appreciate the outcomes have improved over time for this disease. Having said that, we still got to improve in improving outcome of these patients in general. So these are the few slides in which I will talk about the classification and prognostication of AML. As you're all aware, this is the most initial classification of AML called a FAB classification, in which AML patients were further categorized based on their morphologic features. So this classification has not been used, and we have improved and evolved over time and put down a more meaningful classification of this disease. When I say meaningful, which has impact in how we treat these patients and what are the prognosis of these patients. So after FAB classification, there was some improvement in the classification updated by WHO, in which they have incorporated some chromosome abnormalities to further or risk define AML in various categories. Still, a bunch of subcategories are based on morphologic features. Later on in 2015, as you can see, the AML classification further revised, in which they have incorporated some chromosomal features and some mutational features, such as NPM1, FLT3, ITD, and CBP alpha, and in which they further classifies patients into favorable, intermediate, and poor risk group. Among the favorable risk group, co-binding factor leukemias tends to have a better outcome, tends to have a more chemosensitive disease and better response to cytarabine-based regimens. Whereas the poor risk group, in which basically involves the monosomal karyotype AML, or patients who have complex cytogenetics on karyotypic analysis, and patients who have FLT3 ITD mutation. We move further, and we had a more updated classification later on, in which we incorporated more molecular features or molecular profile of AML, in which we further define how we prognosticate and classify patients with acute myeloid leukemia. And you can appreciate in the poor adverse risk group, there is a mutated RUX1, mutated AXL1, and mutated P53 tends to have an inferior outcome. These patients tends to have a more chemo-refractory phenotype. And more recently, with the widespread use of genomic analysis and genomic sequencing, so the classification of the prognostication of AML is further improving. And with the passage of time, we will see that our management and prognostication of these patients will be based on more and more sequencing data rather than chromosomal analysis or cytogenetic analysis alone. So these are the clinically significant mutation commonly seen in patients with acute myeloid leukemia, in which some of them had a predictive value, such as patient with P53 tends to have an inferior outcome. Some patients have more therapeutic value, such as IDH1, IDH2 mutation, and NPM1 mutation, which we can now target these NPM mutation mainly at the investigational level at this point, and in the coming years we will see that we can target NPM1 as well as KMT2A mutation with a targeted therapy. Similarly, FLT3 ITD and FLT3 TKD, though tends to have a poor prognosis, but with the approval of certain FLT3 inhibitors, which we'll be talking about in later part of my presentation, tends to improve the outcome of these patients with this mutation, with better response rate and better survival. Similarly, there's certain other mutation which tends to have a adverse prognosis and tends to have a chemoresistant phenotype, including AXL1 and NRAS mutation. So we have moved a long way in how we treat patients with acute myeloid leukemia. For decades, cytarabine and anthracycline-based therapy was our go-to regimen for patients with acute myeloid leukemia who are candidates for intensive therapy, but it has changed now. So since 2017, approximately 9 agents have approved for various indications, for various subcategories of patients with acute myeloid leukemia. This include therapies like FLT3 inhibitors, namely midostaurin, gilteritinib, IDH inhibitors, IDH1 and 2 inhibitors, and venetoclax, which has also improved outcome of elderly AML patients who are ineligible for intensive chemotherapy approaches. So this table shows the agents which are approved over the last 5 to 7 years, including midostaurin, a FLT3 inhibitor, which is approved for management of treatment-naive acute leukemia in combination with 3+7 chemotherapy. Gemtuzumab, which was taken out of market due to increased risk of veno-occlusive disease, was reapproved by FDA in a fractionated form, and it has shown benefit when combined in good risk AML in improving outcome. CPX-351, which is another novel agent approved over the last 5 to 7 years, which is the liposomal combination of cytarabine plus daunorubicin in a fixed 5:1 molar ratio, which increased the delivery of this agent to leukemic blast. This agent is approved for patients with therapeutic AML or patients who progress from MDS to AML, or de novo AML, which shows a dysplastic features on their bone marrow biopsies. Similarly, venetoclax, which I may not be wrong to say, has been a paradigm shift in management of elderly AML patients who are ineligible for intensive therapy and tends to have a better outcome now with the cooperation of this venetoclax with azacitidine or decitabine or low-dose Ara-C regimen. Similarly, there are certain other molecular targets like IDH2 inhibitor, IDH1 inhibitor, and gilteritinib, which is approved for patients who are relapsed refractory and have a FLT3 IgD mutation. Recently, a couple of years ago, oral azacitidine is approved in patients who achieve remission after induction and are ineligible for transplant or don't have a suitable donor to pursue stem cell transplant. So let me give some time and talk about individualized treatment for AML. As I told you earlier, for years, we used to treat all AML patients similarly, either 3+7 chemotherapy, or patients who are ineligible for 3+7 tends to get hypomethylating agent, azacitidine or Vidaza. But we have come a long way from this, and there has been a paradigm shift in how we manage these patients. So first of all, I would spend a couple of slides in what we are doing different these days for patients with co-binding factor leukemia. As you all know, co-binding factor leukemia includes patients with inversion 16 or patients with translocation 821. They tend to have a better outcome. They tend to have a more response to high-dose cytarabine-based regimen. And these patients should receive intensive chemotherapy, even though if they are more than 60 years of age, but if they have a good performance status and less comorbidity, they should receive cytarabine-based chemotherapy to improve their long-term outcome. After reapproval of gemtuzumab ozugamycin, it is now in NCCN guidelines to incorporate this to 3+7 chemotherapy as well as consolidation chemotherapy. And this false plot on the right side showing a meta-analysis in which they found that combination of gemtuzumab with intensive chemotherapy tends to improve long-term outcome of patients with core-binding factor leukemia. So this is this interesting analysis from Alpha 28 1200 study, in which they further stress the need for risk-adapted or individualized therapy for management of AML. As you can see, even patients who are more than 6 years of age, but who have good performance status and doesn't have much comorbidities, receiving intensive chemotherapy tends to improve their outcome. So if you have a older patients who is fit enough to receive intensive chemotherapy, should be offered, because these group of patients tends to do better with this approach in improving long-term outcome. Vice versa, even if you have a younger patient with poor risk disease like complex cytogenetics, monosomal karyotype, or having P53 or KRAS mutation, conventional intensive chemotherapy won't do much better than low intensive therapy in this group of patients, and treating them with novel agents, enrolling them in clinical trials, or treating them with hypomethylating agent-based therapy tends to do equally better compared to intensive chemotherapy. So another study in which is stressing the need of individualized risk-adapted approach for management of acute myeloid leukemia. If you have a older and unfit patient, these patients tends to have a secondary AML. Secondary AML, they tends to have a disease which is evolved from MDS. They tends to have a chemo-resistant phenotype. They tends to have a more complex cytogenetics. And these patients, even if these patients are eligible for intensive chemotherapy, but having high-risk features, they tends to have a poor response to these agents. And so in these patients, epigenetic therapy prior to venetoclax era has shown to have a better outcome compared to intensive chemotherapy. This is data published by colleagues at MD Anderson prior to venetoclax era, in which they have compared the CR rates and survival rates of patient receiving HMA, hypomethylating agent, versus intensive chemotherapy. As you can clearly see, the epigenetic therapy tends to do better in terms of response rate, 42% versus 28% in terms of relapse-free survival and overall survival. Then recently, in 2020, July, azacitidine was approved in combination with venetoclax in elderly AML patients based on this randomized study of 433 patients in which they compared aza versus azacitidine plus venetoclax. The median age in these patients was around 76 years, and approximately 25% of patients had secondary AML, and 17% of patients had FLT3 and 20% of patients had P53 mutation. So the composite CR rate was significantly improved, which is around 66% compared to 28% with aza alone, which translated into improved survival. Having said that, with this regimen, patients who have a poor risk cytogenetics doesn't show to improve outcome compared to azacitidine alone. Just the overall survival curve, you can clearly appreciate the addition of venetoclax tends to improve the survival outcome in this randomized controlled trial. Then we'll briefly touch on CPX-351, which is a liposomal combination of anthracycline and cytarabine. It was compared to 3+7 chemotherapy in older patients with newly diagnosed secondary AML. And this study, the median age of the patient recruited were around 67%, and 46% of these patients have secondary AML, and among half of the patient had poor risk cytogenetics. So, and this study has shown that CPX compared to 7+3 showed a better response rate. And as you can appreciate here, patients who have a therapeutic AML or entrant diagnosis of MDS tends to have a better response rate compared to 7+3 chemotherapy. These are the Kaplan-Meier survival curves, and you can appreciate this agent, even in elderly patient population, tends to do better and tends to have a lower treatment-related mortality in first 30 days. This led to the approval of CPX-351 for treatment of patient with secondary AML, patient with therapeutic AML, or patient who have AML with MDS-related changes. So there are recently approved targeted therapies for treatment-naive AML. I mentioned earlier. I will just briefly go over the few of the pivotal trials. First of them is a midostaurin, which is a FLT3 inhibitor in combination with 3+7 chemotherapy in treatment-naive FLT3 mutated AML patient. This study involved 717 patients randomized to 3+7 or 3+7 plus midostaurin. Among these patients, 23% of patients had TKD mutation, apart from FLT3 ITD mutation. So as you can clearly see, the improvement in survival, in which in group of patients received midostaurin plus 3+7 chemotherapy, and in subgroup analysis, you can see that patients who not only have ITD high-low, but also TKD mutation tends to have a better outcome. So ivosidenib, IDH1 inhibitor, has been studied in patient with relapsed refractory AML. And this is a phase 1 study by Courtney Donato at MD Anderson. 258 patients were studied. 30% of these patients had poor risk cytogenetics or had a relapse post allogeneic stem cell transplant. This study, if you can see, clearly show better response rate, and response rate were more meaningful with clearance of mutation. They tends to have a better survival outcome. Patients who clear the mutation tends to do better compared to those patients who did response but still have a mutation, IDH1 mutation. Few pertinent adverse effects which you need to be aware of treating patient with the IDH1 inhibitors is QTc prolongation. Patient needs to be monitored by serial EKGs, and we also need to make sure that these patients are not on certain medication that have a tendency to prolong QTCs, like certain antibiotics, antidepressant, antiemetics. Even if these patients are on, you need to be more vigilant in monitoring their QTC intervals. Similarly, around 4% of patients do have a differentiation syndrome at initial part of their treatment that needs to be monitored. And the differentiation syndrome you observe with these IDH1 inhibitor is remnants of differentiation syndrome you see with arsenic with ATRA, and you tends to manage with similarly with managing their fluids, and occasionally we have to give short bursts of steroids for symptomatic patients. So although the IDH1 inhibitor was studied in relapsed refractory population, but it is approved as a frontline therapy in patients who are ineligible for intensive chemotherapy. Now we moved upon indication of targeted therapy in relapsed refractory AML population. Inacitinib is an IDH2 inhibitor, was studied in a phase 1/2 study, 239 patient, and then quarter of these patients had failed to prior lines of therapy, and 1/3 of these patients have poor risk cytogenetics. The overall response rate is around 40% observed, and duration response median was around 6 months, with overall survival improved to 9.3 months. One thing to appreciate with either IDH1 or IDH2 inhibitor, that it takes some time to achieve an optimal response. As you can appreciate with this curve, sometimes it takes up to 7 cycles to achieve a better response. So you don't have to lose heart while putting patients on these therapy. You need to continue on these therapy if they're tolerating well, if they don't have a significant adverse events, and wait for some time before you can expect or see a optimal response with these agents. This is the survival curves in patients who achieve CR versus non-CR, but is still responding. As you can see the below curve, the blue line, these patients didn't achieve CR, but it still tends to do better in patients who didn't have any response. Compared to IDH1 inhibitor, where you see QTc prolongation, IDH2 inhibitor, you see more hyperbilirubinemia, which needs to be observed. You don't see QTc prolongation with IDH2 inhibitors, and differentiation syndrome incidence is similar to what you see with IDH1 inhibitor. So gilteritinib, which is another FLT3 inhibitor, which is approved not for treatment-naive patients, but for patients who have relapsed refractory disease and who progressed on initial therapy based on the phase 3 randomized data, in which they compare gilteritinib single agent versus conventional care treatment, which could be any of the available therapies, cytarabine-based therapies. So we have talked about treatment regimen based on cytogenetic risk and based on approval of certain targeted therapy. Nowadays, there has been a lot of talk about P53 mutation, because this is this is a subcategory of AML in which we haven't seen great responses. These patients continues to do inferior with available therapies we have in our bucket. So I will send a couple of slides on this P53 mutated AML in current time. So these mutations occur in 20% of patient AML, and predominantly 1/3 or half of these patients had a prior history of chemo radiation therapy that defines them as therapeutic AML and tends to have a complex heterogenetics. These patients doesn't respond well to conventional chemotherapy, as I mentioned earlier. So we did a study in collaboration with the 9 academic centers across US, in which we tried to see the trends in outcome with the approval of novel agents over the last 1 decade. As you can appreciate with these Kaplan-Meier survival, progression-free survival curve, this group of patients, this subgroup of patients with P53 mutation, we haven't seen improved response rate across different time periods. These patients were divided into different time periods based on approval of mainly CPX-351 and Vidasa plus venetoclax based regimen. And you can appreciate we haven't seen much difference in outcome across different time periods. So in general, outcome remain dismal with the novel therapies we have right now. But what we found in our analysis, the patients who proceeded to allogeneic stem cell transplant in first remission tends to have a better overall survival. There has been debate about utility of allogeneic stem cell transplant in patients who had P53 mutation, with some reporting inferior or while others reporting better outcome. Our analysis of 315 patients who had a P53 evaluated by genomic sequencing, and we found that patients who went for allogeneic stem cell transplant tends to have a better outcome compared to those who were ineligible for transplant. There are a couple of novel therapies which have been studied for this group of patients. One of them is APR-246, which acts on the P53 tumor suppressors gene in transcriptional activity, and it has evaluated in phase 1b/2 studies, although in combinations with Vidasa or azacitidine showed a better response rate and survival, and patients who receive allogeneic stem cell transplant tends to have a better outcome. However, a randomized study followed by this initial study didn't show benefit of combining APR-246 with Vidasa. And currently, there is a study ongoing in which they are studying this compound in combination with azacitidine plus venetoclax. And there's another agent called magrolimab, which is a anti-CD47 molecular antibody, and it is one of immunotherapy, or you can call a macrophage checkpoint inhibitor, is evaluated in combination with azacitidine, which showed an impressive response rate around 78% in initial studies. And the response duration was sustained up to 7 months when this was reported. Currently, there is an ENHANCE-2 randomized study ongoing in which the investigators are evaluating the safety and efficacy of magrolimab in combination with azacitidine versus physician choice. That could be Vidasa or intensive chemotherapy. Stay tuned to have updates on this study on end of this year. So this is a nice figure to sum up at current era or given time how we should manage patients with acute myeloid leukemia based on their performance status, based on their morphologic, cytogenetic, and molecular profile. If you have a patient who had a fibroblast disease, tends to have a invalid 16 or transcriptine 821, on eligible for intensive therapy, should receive cytogen-based therapy in combination with gemtuzumab, as shown earlier, to improve outcome. And patients who tends to have a poor risk disease, such as therapeutic AML or AML with if available, should receive CPX-351 regimen. CPX-351 regimen has also shown benefit when it was consolidated with bone marrow transplant. So if you have a fit patient with AML and MD changes and candidate for transplant, offer CPX-351, as the expert analysis have shown, these patients who underwent consolidation therapy with transplant tends to have a better outcome. If you have a patient with P53 mutation, and these patients tend to have a inferior response to conventional chemotherapy. Ideally, these patients should be enrolled in clinical trial, and these patients in resource-restricted countries, now Vidase or azacitidine or decitabine tends to do a better job or equivalent job compared to intensive chemotherapy. So something to note. And patients who are ineligible for intensive therapy and have some targetable mutation like IDH1 and 2 mutations can be treated with single agent IDH1 or 2 inhibitor or in combination with hypomethylene agent. Patients with FLT3 ITD mutation and who are eligible for intensive therapy should receive this in combination with conventional therapy to improve their long-term outcome. Certain group of patients is still allogeneic stem cell transplant is indicated, such as patients who have FLT3 ITD mutation, such as patients who have a prior MDS or secondary AML, patients who had P53 mutation, and as per current time, unless we get better therapies, should be offered stem cell transplant if they are eligible to improve their long-term outcome. With this, I will conclude my presentation. So overall, the gist of today's discussion is at the current era, all AML patients should have a risk-adopted and individualized treatment approach rather than treating everyone with one common form of therapy. And clinical outcome, as you can appreciate, has improved, but is still ways to go. Still, the 5-year survival is the range of 25 to 29%. And management of AML is complicated, and it should be treated under supervision of people who treat these patients on regular basis and have expertise of management of this disease. With this, I will thank you all for listening today's talk and discussion, and any questions, comments are welcome.
We'll take the comments and questions in the last. Now we are proceeding to a very interesting next talk by Dr. Bushra Ahsan on management of B-cell acute lymphoblastic leukemia in Pakistan, gaps and challenges. Dr. Bushra Ahsan is a hematologist at Shaukat Khanam Memorial Cancer Center. So she'll be enlightening us with her experience. Can we proceed with the talk?
Assalamu alaikum. My name is Dr. Bushra Ahsan. Thank you for inviting me as a speaker. I'm a consultant hematologist at Shaukat Khanam Memorial Cancer Hospital in Lahore. The topic that was given to me is gaps and challenges in the management of acute lymphoblastic leukemia in Pakistan. It is a huge topic, but I'll try to cover all the bases. I did a preliminary survey across the hospitals in the country, and the gaps and challenges that most of us face are pretty much similar. So the gaps and challenges that we face are starting with the diagnostics and prognostics, treatment decision when it comes to complication of treatment at the time of transplant, and how to monitor and what to do when the patient relapses. When the patient comes, we need to know what the age of the patient is, because we know that ALL rates decrease with advancing age. Many times patients come to us who do not have a national ID card number and do not have a birth registration certificate, and therefore age remains a mystery. Whether the ALL is a B cell or T cell ALL depends on the flow cytometry, for which we need a good aspect sample and timely run test. White cell count, if it's more than 30 in a B cell ALL and if it's more than 100 in a T cell ALL, makes it a higher risk. Once again, when patients come from far-flung areas or they have been treated with steroids beforehand, by the time that they come to us, their pancytopenia, and we never know what their baseline white cell count was. Next come the other prognostic markers, cytogenetics, of which chromosomal analysis and FISH studies need to be done to find out whether there is presence of MLL rearrangement, hypoploidy, Philadelphia chromosome, and other cytogenetic abnormalities. MRD assessment, we cannot stress less on the need of MRD assessment, because we need needed at multiple times, not only at the completion of induction. It can be prior to maintenance, it can be prior to allotransplant, but we cannot go ahead with it unless we have a baseline MRD. Therefore, it is absolutely essential to make sure that you attain a baseline MRD. Which MRD technique do you use? Most of us use a flow cytometry, a 10-color flow cytometry. It is sensitivity of 0.01%. It is quick, can be done the same day. It is sensitive, it is less expensive. Some of us have a PCR-based technique with more sensitivity, and very few have their hands on NGS, which is much more sensitive, but requires more time and labor intense and more expertise. Whatever PCR technique, whatever MRD technique you use, you have to follow subsequently with the same. Presence of the Philadelphia chromosome is absolutely essential to know at the baseline. If you're using a RT-PCR, you should have the PCR technique that can detect 190 kilodalton fusion protein, because that's the one that is found in the Philadelphia positive ALL, unlike the 210 and 230 kilodalton, which is found in CML mostly. Once again, Philadelphia-like chromosome it has to be detected. It has a particularly poor prognosis, and if you are only using a FISH or chromosomal technique that is a traditional one, you will not detect it in the karyotype. If you have particular FISH targeting ABL JAK kinase pathway fusion protein, or you have a reverse transcriptase PCR that identify the ABL JAK fusion partner, then you'll be able to detect it. Therefore, it is absolutely essential to know whether your lab or your facility can detect it or not. Once you have done the initial prognostication and diagnosis, there comes the next challenge, which is the treatment initiation. There are lots of protocols available. Which protocol to choose from? Most of the protocols have the same backbone of the drugs. The BFM protocols, COG regimens, they have 4-drug induction, LGB, 5-drug induction with the addition of cyclophosphamide, UKALL regimens, and hyper-CVAD. And all of them have lots of medications. They're quite intense and aggressive, and last a longer time than the rest of the hematological malignancies. This is followed by consolidation and maintenance, and CNS prophylaxis is incorporated in these protocols. Now, when you initiate treatment, you need to know what is the age of the patient, because you are going to choose whether you're going to have a pediatric inspired protocol or non-pediatric inspired protocol. Now, it has been shown by a number of trials that were done by St. Jude Hospital, by the COG, by the CCG group, by the CalGB, that when young adults are treated with pediatric inspired protocols, they do far better. Their 5-year survival rates are much better. Their survival rate difference was from 40 to 70% in the young adults in the CalGB protocols trials, and it was even up to 90% in the one that were in the COG. Therefore, for practical purposes, we consider 18 to 40 as young adults and treat them as on pediatric inspired protocol, while some centers might prefer other protocols. So now let's see, we have a younger patient who's Philadelphia negative, between 18 to 40 years of age. You start treatment with the pediatric inspired protocol. You keep monitoring them with the MRD, because you need to know whether they qualify for high-risk arms or not. Once they have finished their chemotherapy and they have flown through the chemo and the MRD is negative, they were Philadelphia negative to begin with, this means that you're happy and you do not need to go ahead with the transplant. And this is because this was proven many a times in Dana-Farber consortium, when the pediatric inspired protocols were used, it was found that the patients who were Philadelphia negative and the ones who had only chemotherapy, they had a superior outcome compared to the ones with allogeneic stem transplant. Therefore, we do not need to go ahead with allotransplant in the patients of Philadelphia negative and have achieved complete remission. Now, let's talk about the challenges that we face during treatment with different kind of drugs. One of them, PEG asparaginase, there are lots of toxicities that are expected with PEG asparaginase, including hypersensitivity, hepatotoxicity, thrombosis, pancreatitis, hypertriglyceridemia, CNS toxicity, and these are seen in variable grades. But we do know that all these toxicities are seen more so in the adult patient as compared to in the pediatric protocols, as compared to the pediatric patients. Hepatotoxicity, another real challenge. Many patients present with deranged liver function with a high bilirubin, high LFTs showing high transaminases. The risk factors are higher doses, older age group, high BMI, and also it depends on if you're synchronizing it with PEG asparaginase and other immunosuppressive drugs. This table thus shows that when you use a higher dose of PEG asparaginase, that hepatotoxicity is seen more. Another complication that one faces is thrombosis, and as the graph shows, that the risk of getting thrombosis is higher during induction and in consolidation protocols, and it decreases afterwards, and it's more so in adults. It depends on the treatment and the age, and there has been a number of studies, one of them Therapeutic, the summary of which is that they used unfractionated heparin and prophylactic low molecular weight heparin, and the third arm had antithrombin substitution based on the antithrombin C levels. And the result was that if you use antithrombin or low molecular weight heparin, then we have a low risk of getting thrombosis with PEG asparaginase. However, we do not regularly monitor the antithrombin 3 levels in most of the hospitals here, and therefore the best we can do is monitor the fibrinogen, and if it's really low, to replace it. So how to mitigate all these toxicities that we face with the PEG asparaginase? PEG asparaginase doses vary in different protocols from 500, 1,000, 2,000, 2,500 international units per meter square. And the most commonly used dose that was in pediatric protocols in CALGB and ALS from the COG studies, it was 2,500. However, pharmacokinetic studies have shown that 2,000 international units per meter square is sufficient enough to give the required effect, and then it is completely cleared as well up to 14 days. So when you're giving PEG asparaginase, monitor the liver function test, monitor the serum glucose, amylase, lipase levels, as well as coagulation parameters. There are some studies showing prophylactic use of glucocarnitine for prevention of liver toxicity, but this cannot be advocated. PEG asparaginase should be discontinued in the event of pancreatitis because this can be fatal. And once you have a thrombosis, you have to treat with the low molecular weight heparin as with any other clot. Now, this diagram shows that the relapse-free survival decreases if the PEG asparaginase is used in suboptimal doses. And the second graph here, this shows that if a lower doses of 250 or 500 are used, then the optimal level of asparaginase, which is at about 0.1 international units per ml, is not achieved in the blood, and therefore at least 1,000 international units per meter square of PEG asparaginase should be used. So what we do to reduce the toxicity is that instead of giving 2,000 international units per meter square, we divide it into 2,000 international units per meter square doses in the induction period. So these were the challenges of toxicities. Now the challenge of infections. All of us have great grief due to infections when we treat the ALL patients. This includes bacterial infections, fungal infections, viral infections, atypical infections. And another big issue is the multi-drug resistant organisms that all of us face. So how to get about it? Prophylaxis, which are part of lots of all of the protocols. We must make sure that we do the septic screen meticulously. Culture and sensitivity should be done. There should be active involvement of ID teams and microbiology team. There should be awareness of what is a colonization and resistance prevalence in the hospital. Hospital antibiograms should be revised, and this can help us in some extent to get rid of this challenge. And obviously, once the patient has an active infection, we have to treat as per the protocols of febrile neutropenia and sepsis. Now let's talk about Philadelphia positive ALL. If we have a young patient with a Philadelphia positive ALL, the treatment depends on if you have TKI available. We know that tyrosine kinases are the ones that we need to target to get rid of this malignancy. Which tyrosine kinases do you have available? Do you have more potent ones? We'll talk about this later. MRD assessment, again, very important because we need to tailor and make the patient's treatment, whether the patient gets early remission, whether the person gets delayed MRD remission or never gets a remission, and that will define the subsequent treatment. Again, do we have a transplant donor available? Does the patient have siblings? As we do not have any registry, so we need to make sure if this patient is going to qualify for an ALL, do we have a donor available? Immunotherapies, do you have them available or not? Whenever we talk about Philadelphia positive ALL, two things that come to mind are TKIs and transplant. So in the pre-imatinib era, before the TKIs, we know that the patients with the Philadelphia positive were not doing good as compared to the Philadelphia negative ALL patients. And this was proven by LALA 94 study, where allogeneic stem cell transplant improved the disease-free survival in the patients with ALL when they had a transplant. Similar results were seen in MRC-VK ALL 12 trial, where there was advantage for patients with Philadelphia positive ALL once they had a transplant. And this advantage was further enhanced when they had the imatinib. So from this, we know that traditionally, Philadelphia positive ALL patients are eligible for transplant. And secondly, now the second information that was brought forward was that TKIs are essential for the management. Now, TKIs, which TKIs to use when you have a Philadelphia positive ALL? All of us traditionally started with this first generation TKI, as in CML, and imatinib was the first TKI to be used, and it had shown benefit in number of trials. But as time goes on, we have had more studies showing the benefit of dasatinib, the second generation TKIs. Dasatinib not only has more potent effect as a tyrosine kinase inhibitor, but is known to have additional effects in decreasing the ALL blast number and inducing deeper remission. Now, after dasatinib, we have more TKIs in the market, imatinib. Then the question comes about resistance. Once you have resistance, do you have the facility to check the full detailed mutation analysis? This is a challenge. Most of us do not have the facility to test that, and sometimes the samples have to be sent abroad. Now, the role of dasatinib was studied in the US intergroup study, which was published in Blood Advances in 2016, which showed that addition of dasatinib to induction, to consolidation, to maintenance, and even post-transplant gave a statistically superior advantage to relapse-free and overall survival. And that's how dasatinib gained its popularity as a TKI for the Philadelphia positive ALL. But the story does not finish here. The gap seems to be widening. Now we know that there are more potent TKIs that are available and they're effective. And now there are newer strategies of bispecific antibodies out there. And then immunotherapy plus TKI combination. And last but not least, the cellular therapy. Now, when we are talking about immunotherapies, we need to mention the belantamab and inotuzumab. Belantamab, which is anti-CD19, and inotuzumab is anti-CD22. I will talk about belantamab only because this is the one that some of us have the facility to give it to their patients. So belantamab, we all know, is a monoclonal, it's a constructive monoclonal, bispecific T-cell engager, which engages the T cells by binding to the CD3 of the T cells and binding to the CD19 of the T cells, brings the T cell closer to the B cells and pours in the enzymes and the perforins, which results in the destruction of the B cells. This induces a deep response and a quick response as well. How was this proven? This was proven in a number of trials. Tower 3 study with blinatumomab was used in relapsed refractory ALL patients. In one arm, and chemotherapy was used in the other arm. The results were quite impressive. As you can see here, the median overall survival for blinatumomab was 7.7 months versus 4 months. And similarly, the event-free survival for blinatumomab was 31% versus 12% in the chemotherapy arm. Then the second trial, last trial, where blinatumomab was used in the patients with MRD positive ALL in the again in the Philadelphia negative B-cell ALL. Again, the results were impressive because all these patients who were MRD positive, once they were given blinatumomab, they achieved MRD. In fact, 81% of them had complete MRD response after one cycle of treatment. This shows the deep MRD response that was achieved with the use of blinatumomab in relapse in MRD positive pre-BLL. Another study, ALL 1331 by COG, which is blinatumomab and dexamethasone in relapsed B-cell ALL. Again, disease-free survival and overall survival was much better in blinatumomab than the chemotherapy arm. Now, these trials were up to now with the Philadelphia negative ALL. Now comes the Philadelphia, again, the Philadelphia positive ALL. The Alcantara study, which used blinatumomab in relapsed refractory Philadelphia positive ALL, showed that you can achieve a complete remission or a complete hematological remission in 36% of the patients. And overall, among the responders, 88% achieved the minimal residual negative status. So now the use of blinatumomab in relapsed refractory Philadelphia positive is also coming up. This didn't stop here. We have the dasatinib and blinatumomab frontline treatment for Philadelphia positive ALL, which had shown great results. And this has been published in New England Journal in 2020, which showed an overall survival of 95% and a disease-free survival of 88% in the patients who were Philadelphia positive and received this as a frontline treatment. Even more potent TKI, this is the diagram which is showing the overall survival of 95% and disease-free survival of 88%. Now, another study that shows the even more potent TKI, ponatinib, with the addition of blinatumomab in Philadelphia positive ALL patient, overall survival of 94% and event-free survival of 81%. Now, these studies have highlighted the fact that a more potent TKI and immunotherapy and the combination of these two can get a patients, whether they're Philadelphia positive or negative, whether they're new patients or they are relapsed refractory, they can achieve MRD negative status and a complete remission. So this is not very as simple as it looks like. There are challenges with the immunotherapy as well. For us, the challenges are obviously the availability of the drug. The survey that we did, most of us do not have their hands on the immunotherapy. There's a couple of centers who are using blinatumomab. The cost of the drug, it's quite high. The short half of the drug, which requires a continuous 24-hour infusion, and for that purposes, you need to know whether you have pumps available, nurses who are trained for that, because you cannot keep the patient inpatient for the duration of the treatment. Then once again, the adverse events. We will talk about the adverse events in the next slide. So in addition to the challenges that we don't have these drugs, and since we are not enrolled in trials, we need to know how are we going to use it? Are we going to incorporate it as a monotherapy, as a combination therapy, as a relapse, only in the relapse refractory disease, in the MRD positive disease, as a bridge to allotransplant, or a relapse after allotransplant, or a bridge to CAR T? I think the gap in this, that in which way you use, it can be best unified if we have a leukemia working party, or at least we share the way we are using it to have to bridge this gap as much as we can. Now, it's important when we talk about the immunotherapies, we talk about the adverse events which can be quite challenging to treat. There are neurological side effects that one can experienced with blinatumomab, and in that case, we need interruptions of the treatment. We need to treat for the neurological symptoms like seizures, etc., with the symptomatic management. The cytokine release syndrome is one of the side effects that can be scary, and there are guidelines available as to how to treat this. And if somebody has a cytokine release syndrome, what to do, how to interrupt it. You need to give dexamethasone as a pre-medication, and also during the treatment. Another way to reduce the risk is by cytoreduction, because the higher the tumor burden, the higher is the risk of the cytokine release syndrome. So I will not talk in detail about the CAR-T therapy, because this is a whole topic in itself, but there is no talk complete without mentioning the CAR-T therapy. Therefore, there are a number of trials, as you can see here, which have proven the benefit of CAR-T therapy in relapsed refractory B-cell ALL, and I cannot talk much in detail about this. Firstly, because it is not available at all, and we do not have this here. And secondly, because it's a huge topic and it should be discussed separately. Now let's talk about a couple of slides about the older ALL. So this is a good diagram which shows how the older ALL patients should be treated. If they're older and they're fit, you can give them moderate intensity protocols with the same protocols as used for the younger ones, whether military-based induction, consolidation, and maintenance. If they're older and they're fit and they're Philadelphia positive, obviously you're going to use a TKI. And if the patients are fit, you could consider a allogeneic stem cell transplant. If they're unfit patients, obviously in a Philadelphia negative one, you are going to use a less intense treatment. Probably if they're very fit, you can just use TKI and steroids. And if they're unfit for any sort of chemo, you could consider TKIs and immunotherapies. So these were the few challenges that I tried to touch base. We do have gaps as far as the therapies are concerned, but and it's quite challenging and exciting. It's exciting for the hemato-oncologists to know that the story which started from transplant and very intense chemotherapy might be headed towards only immune therapy and TKIs or a combination of these. But in addition to excitement, there is some anxiety at our end as well, because we want to have more experience with these, and I'm hopeful with time we'll bridge this gap, and we'll be using this more and more. Thank you.
Thank you very much, Dr. Bushra, for a very lovely and enlightening talk. I welcome all my speakers, chairs, co-chair. I hope you can hear me. Dr. Ayaz Mir, Dr. Syed Mohammad Irfan, Professor Usman Shaikh, and my speakers, Professor Srdan, Dr. Clair Harrison, Dr. Talha Badar, Dr. Bushra. It's great to have you, all of you here. And PSH is highly honored to have all of you here, to all my respectable speakers or international speakers who are here with us, in spite of this very odd time for you. I'm really grateful and thankful to you. So we have a lot of questions for you. Our first question, I would take my first question from Professor Srdan. Srdan, how are you?
I'm fine. Thank you very much for having me on the list of speakers today. Such a beautiful list of colleagues and friends I can see on the camera. So looking forward to challenging questions.
Thank you so much for joining. Srdan, your question is, should we consider early transplant in triple negative MF with TP53 mutation at diagnosis who fall in low or intermediate risk IPSS group? And does this mutation alter the course of disease?
A P53 mutation is extremely rare in the myelofibrosis chronic phase. It is seen quite often at the time of transformation. Because it's so rare in the chronic phase, 2 studies at least that I can recall have not shown that it's having a bad prognostic influence. However, triple negative state does show, and it's very well known, bad influence on the overall survival of the patients. However, we would not in everyday practice transplant patients based only on the genetic profile. Whether the patient would have P53 or maybe EZH2 or IDH mutations, which are known prognostically bad factors, that would not influence our decision making. We would look for a clinical progression of that low risk patient to acquire anemia or have a blast or have a symptoms. And as the patient moves up the risk of dying from the low risk to intermediate 1 or 2, then we would definitely transplant the patient. So I would say that genetic information would influence our monitoring plan, and say that we monitor patients more often to see about the clinical progression, prepare the patient for a transplant, have a donor ready, and then transplant when the clinical reasons are present for upping the risk of dying.
All right, thank you very much. The next question for you, Dr. Srdan. Do you find any difference in the clinical response to treatment in CALR mutant MPN patients having marked thrombocytosis?
No. In general, the studies did not show much of a difference between the different driver mutations, the JAK mutation versus calreticulin versus MPL. It is certainly easier to treat the myelofibrosis patients with higher platelets. You have a better chance of providing the better dose, and with better dose, there might be even better response. It is common, however, to have some other mutations, as you know, between 40 and 60% of the time, depends on different study. And there are other mutations, non-driver mutations present in myelofibrosis patients, and unfortunately, those other mutations would overcome the good prognosis of a calreticulin mutation.
Thank you very much. My next question would be for Professor Claire Harrison. Hello, Professor Claire. How are you doing?
I'm good, thank you very much. And I will also echo Srdan's comments. It's a great privilege and honor to be here today. Thank you.
Thank you so much. Pleasure is ours. So for you, the question is, considering leukocytosis as a risk factor for thrombosis in PV, when should we consider starting cytoreductive therapy in low-risk patients who are otherwise asymptomatic and phlebotomy-free?
Well, I think if you have a low-risk PV patient who's asymptomatic and phlebotomy-free, you should think about whether you've got completely the correct diagnosis, because it would be unusual for them not to need a phlebotomy at all, and just occasionally a JAK2 test can be falsely positive. I think there are a few factors to consider here. Cardiovascular risk factors are important and very important to modify for these patients. For leukocytosis, it's difficult to agree a threshold alone, and it's a little bit like the P53 question you asked my colleague earlier. It's unusual to have isolated leukocytosis in an otherwise very low risk patient. If you're asking just about what target would I use, I would probably be considering treating with a white cell count of more than 15 or a rising white cell count. I just wanted to reflect the very interesting data that was presented at ASH by the group of Alessandro Vanucci, showing that a JAK2 allele burden of more than 50% was predictive of venous thrombosis in low-risk patients. So that's something else that I would perhaps consider.
Okay, thank you very much. My next question would be from Dr. Talha Badar. Hi, Dr. Talha, how are you doing?
I'm fine. How are you guys? Thank you. It's a pleasure to be here.
It's great to have you with us. For you, my question is, what is your experience regarding core binding factor AML who relapse or have refractory disease?
In those patients, definitely you need to give, if they are eligible for intensive therapy, you still aim for cure, giving an intensive chemotherapy regimen, high dose Srdan based regimen, and take them to transplant if possible. That would be ideal in ideal scenario. In other situation, you need to manage case by case basis. But ideally, you should go for intensive therapy followed by transplant if they're eligible.
Talha, this is Salman Adil from AKU. How are you doing? So nice to see you.
Likewise, how are you, Dr. Salman? Nice to see you. Nice to talk to you.
Great. Great. Same here. Good luck.
Thank you. Thank you.
Thank you so much, Dr. Talha. My next question would be from Dr. Raheel. Dr. Raheel, how are you doing?
Yes, I'm absolutely fine. And thank you very much. It's an honor and a pleasure to be here today.
It's a pleasure to have you here. Dr. Raheel, my question is, what is your experience, or I would want your comment regarding intermediate risk AML, transplant versus consolidation?
So in our institutional practice, we are actually transplanting all the intermediate risk patients. So there are a few reasons behind that. And one of them is that in Pakistan, we know that we do not have all the genetic mutation testing available with us. Even if we do RT-based, PCR-based testing, there are few transcripts which we are checking. We are not doing any genetic mutation. Moreover, once the patient relapses and they come in CR2, the outcomes are inferior. So once we looked at our institutional data, once we are transplanting them in CR2, the outcomes are inferior. So in our center, what we are practicing is that we are transplanting all intermediate risk patients. If they have got a match-related donor, we actually transplant them. And if match-related donor is not available, then we either do autologous transplant, or depending upon the response to initial induction therapy, we even proceed to haplotransplant. So as an institutional policy, if transplant eligible, we are transplanting all intermediate.
All right. The next question for you, Dr. Raheel, would be, where do we stand in autologous stem cell transplant in AML who don't have a match sibling donor?
So again, there are data to prove that there are no donor comparisons. For intermediate risk patients, if they do not have any donor available, either fully matched or match unrelated, autologous transplant has proven to be superior to high DAC chemotherapy. And there is data even in favorable risk. There is data from, I think there's a data from Switzerland or Sweden, which actually showed that in favorable risk, those with core binding factor beta, if you consolidate with autologous transplant, the outcomes are superior to high DAC consolidation.
Okay, thank you very much. My next question would be from Dr. Bushra Ahsan. Dr. Bushra Ahsan, hello, how are you doing?
Hi, thank you. I'm very well.
It's a pleasure to have you here, Dr. Bushra.
Same here.
My question would be, what is your practical experience regarding adolescents and adult ALL patients? Would you comment upon LSPAR versus PEG?
Well, yes, that is, we have PEG asparaginase available, and I think most of the centers here have that available as well. PEG asparaginase, like any other PEGylated drug, obviously has a longer half-life, stays in the circulation longer, requires lesser number of doses. And if you're going to do split dosing, say if you have a 2,000 international units per milligram of this dose in the protocol, you can split into 1,000 and 1,000. But if you're using an L-asparaginase, then obviously shorter half-life, and you have to use multiple number of doses, maybe more than 5 or even more than that in certain protocols. But still, there are certain protocols which have L-asparaginase in them, like BFM 2000. But we would prefer PEGylated asparaginase, easier to deliver, lesser number of doses, longer half-life, and like all pegylated drugs, better tolerated.
Thank you
But
very
side
much.
effects obviously are there for pegaspargidase, as I mentioned in the talks, and we have to deal with that accordingly.
Thank you very much. My next question would be from Professor Dr. Irfan. Sir, how are you doing?
He's fine, very well, enjoying the session.
Thank you, sir, for being here, for chairing us, and for being part of our panelists. Thank you very much. Sir, what is your experience regarding AML in terms of the newer molecular markers that we have? So what is your experience, data versus practical situations in Pakistan?
Well, I still believe, thank you very much for your question. And I think we had a wonderful talk by Dr. Talha Badar this morning. I believe 3+7 still remains the backbone of treatment of AML all over the world, and particularly in the developing countries, because of the availability and because of the cost management and because of a lot of experience with this drug. But 6 or 7 molecules which have been approved in the last few years, they need to be mentioned. The most important is the HMAs. We had a wide experience in Pakistan of using HMAs for the last many years. And both dasatabine and azacitidine, depending on the availability. And the new addition of venetoclax through these drugs has added to the survival. Otherwise, HMAs add about 12 to 15 months survival to AML patients, particularly older patients who are not fit for aggressive therapy, or younger patients who are, for some reason, they they don't qualify for aggressive therapy. So you can combine HMA with venetoclax. Venetoclax add about 6 months more to the median survival compared to HMA alone. We have a choice of low-dose cytosar also. Low-dose cytosar is very cost-effective in Pakistan, but venetoclax is very expensive. One cycle will cost more than 1 million rupees, which is a tremendous cost with us. The other 2 important targeted drugs, as mentioned by Dr. Talha, midostaurin, the FLT inhibitor, and the gemtuzumab ozogomycin, GO, anti-CD33. I have not used them, but I know they have been approved in appropriate patient setting, and they add to the survival. But again, these drugs are not curative. They do not have the curative potential, as far as I know, to this time, and they are usually given in combination with cytosar. Still, other drug is the IDH1 and 2 inhibitors used in new patients and in relapsed refractory patients. They are a good hope in elderly patients, I fully agree, but again, their curative potential and long-term outcome still remains unknown. And still others are, as again mentioned by Dr. Talha, is the liposomal daunorubicin and cytosar. Again, this is a good hope in patients who cannot afford the aggressive therapy or in relatively older population. So there are other in pipeline, but again, I would think that 3+7 or HMAs plus minus low dose cytosar are the best choice in our country.
Thank you very much for sharing your experience, Dr. Irfan. As part of our panelists, we have Dr. Aisha Jamal here. Dr. Aisha, since midostaurin is not available in our part of the world, and since you practice acute leukemia at NIBD, so would you like to share your experience regarding sorafenib?
Yes, since we don't have midostaurin available for now, there are certain patient access programs that can provide it, but it's difficult to acquire, and by the time we get it, the patient has already been treated with something, or we have lost the patient. So what we are doing, we are adding sorafenib, and there's a good data with the sorafenib trials that have been added in the induction 3+7 regime, and we do add it, and then we are basically using two cycles of 3+7 with sorafenib, And after that, we usually proceed with transplant, and then we go for the maintenance with sorafenib as part of the SORMIN trial that we have all seen that it works for the patients. So yes, in the absence of midostaurin, sorafenib is a good option. And as we don't have this gilteritinib available or other targeted or more specific FLT3 inhibitors available for the post-transplant setting, so in that setting, we are also using sorafenib. And so far, we have a good experience. The patients are going into the remission. There's a higher number of patients who go into the remission who basically receive sorafenib in the induction phase compared to the ones who do not get sorafenib in the induction phase. And all in all, it's a good experience so far. And I don't know how to compare the two for now, since we haven't used midostaurin as of yet. But yes, in the absence of midostaurin, sorafenib is a good option, a good FLT3 inhibitor that can be used in that setting.
Thank you so much, Dr. Aisha. Dr. Uzma, you have questions.
Yes. Hi, Professor Clair. I have a question for you. I just need your comment or opinion regarding the use of ruxolitinib as first-line treatment in high-risk polycythemia vera patients, especially those who present with thrombosis, with history of thrombosis, or who are diagnosed with MI or stroke, and recently at the same time they present with polycythemia. So do you prefer to use ruxolitinib, or does it give any additional benefit if we add ruxolitinib as a first-line treatment in these patients?
So ruxolitinib isn't licensed for first-line use for treatment of polycythemia vera, and in general, either using hydroxyurea or interferon where it's available would be my preferred option. It's a perfectly reasonable therapy in the second-line setting, in the settings you describe, but we would have to be careful about the tendency for this drug to make patients put on weight and increase their cholesterol and their blood pressure for patients who have arterial events. Currently, we are trialing ruxolitinib in the first-line setting in the UK and France, but that's a completely new question, really. The only time when I think it could be potentially extremely useful is in a patient where standard therapies don't control severe disease-related symptoms, in particular pruritus.
Okay, you're right. Thank you.
Thank you.
Professor Srdan, I want to ask a question from you. Can you share your experience of treating accelerated phase myelofibrosis patients who have a certain percentage of blast cells in circulating blast cells, and who otherwise have a stable disease? I mean, and they are younger in age as well. Since in our population, MF is diagnosed at a pretty younger age. Median age of diagnosis of myelofibrosis in our country is 38 to 40 years. So, and these patients, with gradually with the passage of time, they develop circulating blasts, and we don't really have the option of transplanting them. So, can you share your experience of treating such kind of patients who have circulating blasts, and what is your opinion regarding the use of hypomethylating agents in these patients?
This is a really good, very important question. The tendency for progression to accelerated phase, and I believe you are asking me about that, this would be 10 to 20% blast, and of course then acute myeloid leukemia is very important. In our standard practice, we don't really, in terms of management, distinguish between the accelerated and blastic phase anymore, where anything that is 10 plus is treated the same way. We know that patients that have 10 to 20% blast have an average survival of a year and a half, and the patients that have 20 plus blast about 6 to 9 months. So we don't really wait for patients to go from 15 to 75% blast. You start therapy when the patients reach above 10. And it's standard practice to use hypomethylation agents. And I'm glad to hear that you have at your disposal azacitidine or decitabine. Either one is fine. The 50-50 chance exists with either one to decrease the blasts. You don't really go for complete response. That's not very common. But Dr. Badar here has a hands-on experience. He was working with me for a couple of years and published our experience at MD Anderson with this regimen. So we would use hypomethylation agents and add the ruxolitinib if it's not already there at a dose of 10 milligrams twice a day to control the symptoms, and not change the ruxolitinib at all based on accounts, just to have that quality of life there as well. And before I ask Dr. Badar to share experience, I also like to mention venetoclax. It was mentioned that it's very expensive and it may not be available to you, but we do not use it in accelerated or blastic phase patients that had prior MPN. In post-MPN AML, the biology of the disease is different, and the venetoclax doesn't have a major role. Makes people myelosuppressive. Myelosuppression is a problem. Unless you immediately do the transplant, they usually have a complications and die from sepsis. And so we try to avoid venetoclax in post-MPN AML. Dr. Badar, nice to see you.
Likewise, how are you, Dr. Verstovsek?
You look as young as always. Tell us a little bit about your experience. I am sure you have much more experience with hypomethylation agents in accelerated and blastic phase since the times you were at us at MD Anderson.
Oh, nice to see you, Dr. Verstovsek. It was a pleasure working with you those times. And once again, hi and hello to my colleagues, Dr. Shaikh, Dr. Salman Adil, and Dr. Zaidi, who are here. So definitely, as we both work together and publish data on decitabine, role of decitabine in patients with MF accelerated phase and plastic phase, and we did show, though the stringent criteria for CR wasn't achieved in all patients, but patients who responded tends to do better and tends to do better. And then combination of resultant also helps. As I mentioned, you recently published study from your group in combination with venetoclax with decitabine didn't show much advantage. And none of the patients who had MF accelerated phase or transformed to AML had achieved CR. Correct me if I'm wrong. So venetoclax hasn't shown much benefit in this particular group of patients. And if you're lucky and after having some response to hyperthermic agent, if they're eligible, taking it into transplant is the one approach which can improve outcome in some very subset of patients, I would say.
Yes, thank you. I agree.
Thank you very much, Dr. Talha. Since we are short of time, so I would like to conclude this very interesting, informative session that we had. I would like to thank all my speakers who took out their time. In spite of all the inconvenience, they joined us. I wholeheartedly thank you all on behalf of all PSH Forum. Thank you so much. In the end, I would like to take concluding remarks from my chair, Dr. Ayaz Mir. Dr. Ayaz Mir, hello, how are you doing?
Assalamu alaikum and good morning. Thank you for giving me the opportunity. A very enlightening and complex talks. I think we know the field as a whole is moving towards molecular targets, and our dilemma in this part of the world is to get hold of these molecules in a cost-effective manner. I think my mentor and teacher Raheel Iftikhar still believed that ruxolitinib does not alter the natural history of the disease. We still have not had very successful drugs in trying to prevent conversion to AML and to myelofibrosis in PVERA and JAK2. But I think we are making progress. One of the challenges that was not discussed in these talks is the pre-fibrotic myelofibrosis, which sometimes present a diagnostic and a treatment challenge, what to do with these patients because it's relatively rare. I thank all the participants very much, and I know some of them are off the clock in time zones, and it's difficult for them to be with us at this time. But on our Pakistan Society of Haematology behalf, I'm very thankful to all of you for your input and kind presentations. Thank you.
Thank you so much. I would also like to take concluding remarks from my co-chairs, Dr. Syed Mohammad Irfan and Dr. Professor Usman Shaikh. Dr. Usman, are you with us? Can you hear me?
Yes, I'm just hearing you, and there's very good talks by all these speakers, and very good question answer session. And because of in the interest of time, we should conclude now. Thank you.
Thank you very much, Dr. Nida. Thank you very much. You conducted this session very well and very timely. And we have some very eminent talks and we had eminent speakers. I particularly enjoyed the talk by young Dr. Talha Badar, because
Thank you so
AML is
much.
my favorite topic and I really enjoyed his talk. And thank you very much, Dr. Talha, for being with us. And thank you very much for all other speakers and my colleagues and panelists and chairs and co-chairs for sparing time. And we will remember this session for a long time, inshallah. Thank you.
Thank you,
Thank
Dr.
you so
Irfan. It was
much.
a
So
pleasure
with
to
that,
be here. Thank you.
Thank you so much. So with that, I would conclude this session. Thank you very much, all of you.
Thank you.